Present today on a procedure that I developed a number of years ago. And it's really turned cardiac surgery somewhat upside down because it's not what most people are used to. There's a lot of heart surgery done in this country, somewhere in the range of 500,000 people a year get heart surgery. And of that 500,000, almost 350,000 are coronary bypass. Everyone is familiar with coronary bypass, triple bypass, double bypass, quadruple bypass. Those are very common operations. And typically they're done through what I call the zipper, an incision right down the middle of the chest, about 11 to 12 inches long, that divides the main bone on the sternum. This procedure is been around since the 70s, actually even before that, but it became mainstay in the 70s and 80s. And we really haven't changed much over the years. So I developed this procedure, what I call mixed CABG. I'll go over some of the details just so you get a little better idea, but this is the way it's done. There are basically three incisions. There's an incision in between the ribs on the left side, and then there are two other incisions through which we can put these specialized devices that move the heart around and position the heart so we can do the bypass surgery. We've gotten so much press about this that we've had surgeons from all over the globe coming to watch how to do the case and learn the technique. And it's gotten to a point where it's being done just about everywhere in the globe. I've been all over the globe teaching and mentoring and helping surgeons learn how to do this procedure. We've gotten to a point where we can just about do any patient this way. Let's skip that slide. So one of the things I'd like to talk about is endpoints, and it may be familiar to some of you, but maybe not. Endpoints are typically what we as investigators use to decide what is going to be the goal of our article or goal of our research. And the physician-driven endpoints are things like, did the patient have a heart attack after surgery? Did the patient have a stroke after surgery? Did the patient have death after the surgery? These are all called MACE, major adverse coronary and cerebral events. It's very technical, but as we have emerged as more like a fast food society, we want things done quickly. The focus for the patient has changed. No longer is death really the biggest concern. As a matter of fact, there was a study done in the mid 2000s and it was a survey study that asked patients who are under or facing a life-threatening surgery what their biggest concerns were. And you would think that a life-threatening surgery, the biggest concern would be, am I going to die? Am I going to make it through the surgery? It turns out it wasn't number one. Number one was, how much pain am I going to have? And then the question was, well, what is your number two concern? And making it through the surgery was not even number two. Number three was making it through the surgery. Number two was, what's my quality of life after I have this life-threatening surgery? Because quality of life has trumped death as far as most patients are concerned in our current society. So the way it is right now is that we have a choice between two different opportunities to fix the blocked arteries in our heart. The one on the left is through a groin stick, an angiogram, and the one on the right, which is a major big operation, 12-inch incision and so on. The difference between the two is monumental. I mean, the one on the left, you stay in the hospital for one night and you're home the next day. The one on the right, you're laid up for 3 months. So the way I was thinking about it is that we need something in the middle, something that is able to do as much as you can through a main incision, but more minimally invasive. The history of minimally invasive cardiac surgery goes way back. As a matter of fact, the original article on minimally invasive coronary bypass was done by a gentleman named Kolosov in Russia. As a matter of fact, it was called Leningrad then. That was before they changed the name of the city and part of the USSR. He did minimally invasive thoracotomy based mammary bypasses to one artery on the heart, which really started the whole thing. But it kind of fizzled because once the sternotomy and the heart-lung machine became available, it became so easy that any surgeon could really do this kind of surgery using the heart-lung machine and the sternotomy, meaning the main incision. So we got to a point for decades, we were using this technique of going on the pump and using the main incision called a sternotomy. And then people started dabbling with minimally invasive techniques in general surgery, orthopedic surgery, GYN surgery. And I thought to myself, oh boy, we are way behind the eight ball that we haven't had developed our own minimally invasive platform to accomplish the goal of bypass surgery. And as a matter of fact, if you look at the history of the gallbladder, which I think is a very fascinating one, in the late 80s, most everybody had the big old incision on their belly to get their gallbladder out. And then within a decade, everyone was getting 3 or 4 holes in their belly, getting laparoscopic cholecystectomy. Now no one gets the main incision. They get the laparoscopic technique to get their gallbladder removed. So let me go a little bit into patient selection. And I have this slide, and I use it as sort of a stimulation for conversation. But there are really basically 2 categories of patients I see. And the first category is the more common. I see twice as many category 1 as I see category 2. But the category 1 is those who want it. These are typically people who find out that they have blocked arteries in their heart and they need open heart surgery. And they're told you need a triple bypass, you need your chest cracked open, you're going to be laid up for 3 months, and it doesn't sit well with them. Now, those patients are typically breadwinners of the family who have to work to pay for whatever expenses they might have, or there may be people who are retired and want to get back to their normal activity, or regular people who just can't afford to be laid up for 3 months. So I get a lot of people seek me out for that reason, because our procedure, you can literally go back to normal activity about a week after discharge. But there is another category, and I call it those who need it. And this category is important because there's a lot of patients like this, and they're typically older, they're deconditioned, and I could really describe it to you by just telling you about a patient I operated on about a year ago. It was a 82-year-old gentleman who came in the hospital with a fractured hip. And when they were working him up before he went to get his hip fracture fixed surgically, they realized he was having chest pain. So they did further workup on him, and they found out that he had blocked arteries in his heart. As a matter of fact, he needed a triple bypass. Now, this is a guy who's been laying in bed for 3 days, 82 years old. He's got other issues like diabetes and high blood pressure. The last thing you need to do is to crack his chest open and subject him to a major operation, and then have to fix his hip as well. So it really becomes a challenging situation for anybody, but an older person like this, you really, the last thing you want is to have such big operations back to back. And there's a lot of patients like that. All right, let me get on to the next slide here. Okay, some reason my slides, oh, there we go. So is there anybody, I get this asked all the time, is there anybody that you would not operate on? And I see somebody asked a question about doing emergency cases. Typically, emergency cases come in different flavors. If it's a real dire emergency, no, we will not do it this way. But if it's a moderate emergency, yes, we can do it minimally invasive. Just to give you a little example of my practice, I think we do about 98 to 99% of our patients minimally invasive. We do the most minimally invasive coronary bypass in the country, probably the world. So I'm asked all the time, are there people you would not do a minimally invasive bypass surgery on? And the answer to that is probably not many, but there are some categories that the operation is very challenging. I will just advise you that this slideshow is a slideshow that I give to actual surgeons who come to learn how to do the surgery. So I'm adapting it to anybody. But some of the big challenges are in obese patients, because we're trying to go through a little hole, and when you have 2 or 3 inches of fat layered between the skin and the target, it makes it a little challenging. I will say, however, like I said before, about 98% of the time I'm doing it minimally invasive. So these are what I call relative contraindication. Some patients have severe circulation problem in their lower legs. Those are ones you might want to consider doing the old-fashioned way. And then there are occasionally a patient that has very diffuse coronary disease that you would get better exposure if you opened them up and did it the old-fashioned way. This is a video clip of a presentation I made in 2014. at one of the major conferences. And I just want to show you how the surgery is done. It may be a little gory, so you might want to squint your eyes closed if it gets to that point. But you'll see there are three main incisions. There's one under the xiphoid here. There's the main incision through which you see me working. It's a little slit. And then there's a third incision, which you can't see here. And you can see I'm harvesting the internal mammary artery. That's one of the arteries we use for the main bypass. We also use arteries from the wrist and arteries also from the right side. That was the left artery. We also have a right artery. On a rare occasion, we'll use veins from the leg. We try not to use the veins from the leg because, number one, they don't last as long as the arteries. And number two, they have a tendency to, they have a tough time healing frequently. Patients really complain a lot about the leg harvesting. All right, here we're opening up the pericardium. Again, we're going through a little slit you can see here, and we're taking a look at the heart. And you can see the heart bouncing around there, and we're setting it up so that we can create these bypasses. Again, we're not opening the chest. We just make a little slit in between the ribs, and now we're going to position the heart so we can actually start sewing the bypasses. Now, again, keep in mind, this is the videos I actually show physicians who are training and learning how to do this. So it's very real what's going on here. So this is the aorta, the main artery coming out of the heart. And what I'm doing with that is I'm finding a spot to connect my bypasses to. This is called the ascending aorta. And again, you can see I'm working through a very little slit in between the ribs. And this is me just preparing the aorta for bypass surgery. And once I get that strap and that tape around the back of the aorta, I can pull it up so I can really see it nicely. And you can see how easy it is to get to when you perform all these steps using all these minimally invasive tools. Now, through this little slit, we're going to put a clamp on the aorta, and we're going to create one of the first bypasses. But you can see in the background, the heart is still beating. And you can see on the EKG, you still have the normal rhythm with the heart beating. So we don't ever stop the heart during these operations. The old-fashioned way, which is the way it's done in most of America, the heart is stopped and the body is cooled down. But in this type of operation, we keep the heart moving throughout the whole case. So you can see two grafts are attached to the top of the aorta in this particular scenario. And I think this patient ended up getting a triple bypass or a quadruple bypass. I can't recall exactly. But you can see the bypasses are connected to the aorta, so they have already blood flowing. This is what we call a positioner. This is a device that sucks onto the end of the heart, and then you'll see we move the heart around so we get to the vessel we want to. This is a right coronary artery bypass, so we're going to go right to that artery right there. This is the positioning for an LAD, which is one of the big vessels on the front of the heart, and that's the bypass right there, and we're completing it and giving new circulation to the patient. So I know it's a little gory, it's a little quick view of how things work. But I just wanted to give you just a general idea. This case I show my colleagues because you can see the incision a little bit better, but also this is a single bypass, and it took us about an hour and 10 minutes to do this case. So I demonstrate this to surgeons whenever I travel around the world or when they come to visit me. I show this video to them. So let me talk about post-op. All the patients that I do get what we call a pain pump. So all that is a infiltration of a lidocaine, like substance called Marcaine. But that substance basically numbs the incision. So most of the patients have very little actual incisional pain. Some may have some back pain or shoulder pain from the positioning on the table, but by and large, the incision is not really much of a concern about pain. The pain pump stays with them for about 4 to 5 days. Once they're out about 2 or 3 days, the pain is quite a bit diminished, so there's really no need for that. In addition to that, we do not apply any restrictions to our patients. So because we don't break any bones, we don't cut any muscles, the patients are literally allowed to do whatever they want, whenever they want. I typically tell them to listen to their body, make sure they're ready to do it, but they can literally drive themselves home from the hospital. They can lift, they can go swimming, they can do whatever they want to do, as long as they listen to their body and make sure they don't overdo it, fall and break a leg or something like that, which would really hold them back from getting where they want to go, which is back to full recovery. We target a 2-day post-op stay. It typically is more like 3 days. It depends a lot on the individual and the family circumstances and the social setting. Some of the older patients stay a little longer, and then some of the sicker patients who have other things going on stay a little bit longer. I'm going to give you a little story about Joe. Joe actually is a plumber, and he was told that he needs triple bypass, and he had a business, a small business, but it was a business that he couldn't actually take off from because he had too many financial obligations. He had 2 kids in college, he had a mortgage, and he only had one worker that worked with him. So Joe was able to find us to do a minimally invasive triple bypass. He went back to work, supervising his plumbing jobs within 7 days of discharge. And you see the big smile on their face because, quite honestly, yes, his life was saved. He prevented him from having a heart attack that could have been fatal, but their financial life was also salvaged. And I think it was really important to them because he really did get back to work. I'm going to introduce you to another patient. This is a patient we did here at Baptist only a couple of weeks ago. And this lady is actually a very sick lady, came to us with both aortic stenosis, meaning one of her valves was tight, that was not opening properly, and coronary blockages. So she needed both a valve replacement and coronary bypass surgery. So in any hospital in this country, including anywhere here in Miami, that patient would get the traditional incision and get both operations done within one incision. But at the MCVI, Miami Cardiovascular Institute, we were able to take this patient and get a brand new valve through a groin stick. We threaded a valve up through the vascular system, expanded it inside the aorta. So she got a brand new valve. The next day, we took her to the operating room and we did a minimally invasive bypass surgery, from which she did very well. And she literally is ready to go home 3 days later. And you can see this is post-op day 2 or 3, I can't remember. And you can see that she's up and walking around and ready to get back to normal life. So we're very proud of her progress, and she did very well. And she's very excited to get back home so quickly. Here's another fellow that we operated on a couple of months ago. Actually, I think it was like around July or June of last year. And John Reagan is a runner. And one of his big concerns was that he wanted to get back to doing what he does best, and that is running. He had, it's very hard to get into the Boston Marathon. You got to qualify, and he was all set to run, and then found out he had coronary artery disease and needed coronary bypass surgery. So he found us, and we were able to deliver to him a successful minimally invasive coronary bypass surgery. And here you see him running the Boston Marathon only a few months later, and you know the training involved in running a marathon, especially a tougher like the Boston Marathon. I'm not going to get much into the data and the details of the data. I think we'll rather save some of the time for questions. Let me see what I have left on my slides here. Okay, so I want to show this, and I show this to all the surgeons that visit. And the reason I show this is because this is a CAT scan of a patient who had a minimally invasive coronary bypass. And you can see the arteries and veins that are bypassed here on the heart. And if you compared it to the open case that's done through a sternotomy, you'll find out that the CAT scans look almost indistinguishable, because what we're doing through the little incision is almost exactly the same operation. We're just doing through some small holes using some very ingenious devices to move the heart around and stabilize the arteries. So in summary, I think that there are a couple of things that I will talk about based on this slide. First of all, I've been doing this since 2005, and I've well past 2,000 cases, and we have tremendous outcomes. Patients are doing extremely well. As a matter of fact, most of my patients are back to normal activity within a week of discharge, and extremely happy about the outcomes. But what I'd like to talk about is the synchrony with technology. Technology is the key for us doing what we do. We can't get these procedures done unless we have technological advances in engineering and devices and so on that facilitate our capacity to do this operation. And we've been partnered with several industries to constantly fine-tune the devices and the techniques we use so that we can get the best possible surgery and the most minimally invasive surgery we can out to our patients. And I think we do that pretty much on a regular basis. So thank you for your attention to this. I know that there are several people online who will probably have some questions. I see that there are 3 questions, and I'm going to answer those questions, then we'll throw it back out there. Okay, so let's start at the top. The first question: you don't have to stop the heart during your procedure. That is actually correct. We actually never stop the heart during, and most of the way it's done in the rest of the world is that the patients have their heart stopped, the heart's cooled down, and then the hearts have to be rewarmed and then restarted, so that those patients, on occasion have a lot of arrhythmias and sometimes have trouble getting the heart restarted. So you'll see in TV shows and movies that they'll put the electrical paddles on either side of the heart and shock the heart to get it back to regular rhythm. But we don't have that because we don't ever stop the heart. The heart beats normally throughout the whole case. About the negative harvesting of the legs. Okay, so I mentioned before that we here at Baptist in Miami Cardiovascular Institute, we basically try and stay away from the legs best we can. We frequently do have to use vein grafts from the legs, but the arteries do last quite a bit longer. And then the other thing is that the legs are under pressure because of standing. So that sometimes the wounds get swollen, the legs get swollen, and patients complain about that quite a bit. Let's see, we have another question. Is there a downfall to this procedure as opposed to the normal way of doing heart surgery? I wouldn't say there's any downfall, as a matter of fact. As a matter of fact, I'm going to say that there's advantages, and they've been scientifically proven. Some of the big advantages are bleeding. There's far less bleeding with this technique than there is through the regular approach. We've shown that scientifically that it's quite a bit different. We have a way lower stroke rate, and I'm talking about way lower. There are other advantages like less pain, obviously. And as far as success in getting the job done, we are just as good as the open surgery or better. And we've done a study. I skipped over it quickly. I didn't think people would be interested. We did a study where we followed 100 patients consecutively, and the results were outstanding. So I think that actually the answer to that question is the opposite. How long is a typical valve replacement surgery? So I do all my valve surgeries minimally invasive. And I would say that for a mitral valve, it's probably about 3 hours. Aortic valve, maybe a little bit less than that, 2.5 to 3 hours, typical time. And so I have one more question here, and that is, can you resume exercise soon after? And the answer is absolutely yes. I have many patients who are avid exercisers. They're including the example I gave you on the slides there. John Regan was so upset about having to stop running that when I told him, don't worry, you can stay running, it's not a problem. We don't break any bones, we don't cut any muscles, there's nothing structurally wrong with you when you finish with this operation, so you can get back to doing anything. I even have patients doing golfing. We have patients getting back to martial arts. The only thing I tell my patients is just listen to your body. You may be a little bit more run down after going through a surgery like this, so you want to make sure you can tolerate what you're proposing to do, because the last thing you want to do is try and do something and then fall because you get tired and break a leg or something. So I always say listen to your body, but there's absolutely no restrictions on these patients post-op. I see there is a chat here. Okay, let me read the chat now. I have 2 spherical valves. Absolutely, yes. So one of the people online has a leaky mitral valve and a leaky tricuspid valve. Can those things be solved by minimally invasive cardiac surgery techniques? Absolutely, we do it all the time. The mitral valve is probably the main problem in this particular case, and the tricuspid valve is a secondary issue. but typically both of them need to be fixed at the same time. There are also transcatheter techniques, which we at MCVI and Baptist are experts at. In some certain cases where we don't even have to do surgery, we can do what's called transcatheter. We go through the groin and fix some leaky valves. So there's a whole lot of, our field is evolving so rapidly that it's almost impossible for the public to keep up with it. So that's why I love doing these kind of seminars or webinars, just so people can get a little bit of a inside look at how far we've come and how fast we're going to the next level. So we're literally creating the leading edge here, and it's exciting because every time I turn around, there's another advancement, another hurdle that we've overcome to make things better for our patients. Okay, now let me see if we have any more. Yes, we have another question. All right. Okay, that's not a question, but I like it. Great information. Thank you. Appreciate the comments. Anybody else have any questions?
Thank you so much, Doctor. This was very informative. Thank you for your time. And I think we don't have any more questions. We've covered them all. So thank you so much. And I want to thank everyone for joining. I'm going to be sharing my screen right now to share a quick QR code for anyone to give us your feedback. We appreciate if you took a moment to take this survey. So I'm going to share that right away. So thank you all.
Yes, thanks everybody. I appreciate you giving me a chance to show you what we do and show how bright the future is for patients who end up coming down with these problems. You know, we really are moving this thing ahead very rapidly, and we're very grateful that we can help as many of you people out as possible. So thanks for tuning in. Appreciate it.
Thank you so much, Doctor.